this is Dr. Michelle Clayman, and this is a presentation on take-home naloxone. I work at a few different places. One, I work at a community opioid clinic called True North Medical, and then I also work at St. Mike's Hospital as an emergency physician and an addiction medicine consultant. I have nothing to disclose today. The learning objectives for today is to first understand the rates of opioid overdose in Canada, although I do have some American stats to show you. Second, to recognize the signs and symptoms of opioid overdose. 3, learn how to manage an opioid overdose. 4, how to understand the role of take-home naloxone. And finally, to identify resources for naloxone training of your clients. So you're all familiar with the faces on this slide. We have Prince and Philip Seymour Hoffman and a few others, and these are celebrities that we know have overdosed on opioids and have unfortunately died. However, we have to remember that opioid overdose just does not affect people who abuse opioids. Think about the 80-year-old grandmother who takes a few extra Percocets on a Wednesday because her back pain is flaring up, or a child who gets into his mother's methadone dose in the fridge and overdoses on opioids. So even though these pictures are representative of some famous people, we have to start thinking about others who might be at risk for opioid overdose. When we look at the statistics for opioid overdose in the States specifically, this bar chart is from the National Institute of Drug Abuse. What we're seeing over the years is that there's been a huge increase in the number of deaths involving opioids. This specific slide is relating to heroin, and it shows the total number of overdose deaths from 2001 to 2014. The chart's overlaid by a line graph showing the number of deaths by females and males. And what it's showing is that from 2001 to 2014, there was a 6-fold increase in the total number of deaths due to heroin. When we look at number of deaths related to prescription opioid pain relievers, we're seeing a very similar trend. So this bar chart shows the total number of U.S. overdose deaths involving opioid pain relievers from 2001 to 2014. Again, it's overlaid by a line graph showing the number of deaths by females and males. And the take-home point from this graph is that from 2001 to 2014, there's a 3.4-fold increase in the total number of deaths. People are dying of heroin, but they're also dying of prescription opioid pain relievers. Bringing it a little bit more local, I want to tell you the story of Tina Espy. So Tina was an 18-year-old female who lived just north of Toronto. Unfortunately, she had been having problems with prescription opioids for many years and unintentionally overdosed from fentanyl on December 10, 2012. It was a very sad story. This was a girl who was a good student, went to school, and does not look like the typical drug user. So I just want to keep that story in mind as we go through the rest of the presentation. Recently, there's been an increase in overdose deaths, especially in Toronto. This alert was posted by Toronto Public Health on June 3rd, and what it showed was that there's at least 8 overdose deaths in downtown Toronto over the past 3 days. 6 of these were in the Moss Park area, with 1 death and 1 hospitalization, and then there were a couple in Parkdale as well, and all these overdoses included heroin. What we're seeing now in Ontario, and specifically in Toronto, is that fentanyl is contaminating the heroin. It's bootleg fentanyl, which is 40 times more potent than heroin. So people who are using heroin are using the same amount of heroin they normally do, however, it's now contaminated by fentanyl, and therefore people are overdosing and people are dying. What Toronto Public Health has recommended is that people who use heroin do use a buddy system, so use with people they trust and not alone. Avoid mixing their drugs with other sedating substances like alcohol and other opiates. And they have asked the people who use drugs to actually know what they're smoking or injecting. So does it smell, does it taste, or does it look right? And they also recommend a test dose prior to using the full dose. And then the big take-home point from this opioid overdose alert is that they would like people to have an overdose response plan. So get a naloxone kit, learn CPR, etc., and call 911. When we look at the coroner data in Ontario, we're seeing very similar patterns than what we're seeing in the States. So this graph is a total number of opioid toxicity deaths in Ontario from 2002 to 2014. And this is a combined graph, so all the opiates are listed on the right, so oxycodone, morphine, methadone, hydromorphone, heroin, fentanyl, and codeine. And what we're seeing is that overall, the deaths are going up related to all these opioid substances. So it's not just heroin, it's not just fentanyl. We are seeing deaths from all the other prescribed opiates as well. When we break it down by drug, specific opioid toxicity deaths in Ontario between the same time period, what we're seeing is that the majority of deaths have been related to oxycodone. There has been a few deaths related to heroin, but really it is those prescription opioids medications. I just want to draw your attention to methadone being involved in over 1,000 deaths. And that could be either methadone that's prescribed or it could be methadone that's purchased on the street. Next slide addresses the fentanyl-related problem we're seeing in Ontario. So yearly and total cumulative opioid toxicity deaths in Ontario between that same time period, 2002 2014, is going up. We're seeing the cumulative number of deaths over the years have been 826. I think this number is going to continue to rise as we see more and more fentanyl contaminating our heroin. If I haven't convinced you that opioids are a problem in Ontario, I just want to draw your attention to this very interesting article that was published on CBC in the summer of 2014. This was a study that was done by Tara Gomes and her colleagues over at Lika Shing at St. Michael's Hospital. And what they found is that OxyContin and other opioids is tied to 1 in 8 deaths in young adults in Ontario. And that was quite shocking to me, almost exceeding motor vehicle accidents. This followed by another press release in November 2014 that showed that prescription for high-dose opioids is on the rise, and the rates are going up. They went up from 781 units per 1,000 people in 2006 to 961 units in 2011. So physicians are contributing to the problem. We're prescribing too many opiates to people, and they're getting hooked, and then they're overdosing. I want to talk about a case study. Jake is a 34-year-old male who has a significant opioid use disorder. He was prescribed oxycodone and acetaminophen 5 years ago for a back injury and then quickly escalated to IV heroin. He unfortunately developed tolerance and had a lot of pain and then was supplementing his oxycodone that he was prescribed. He's had a few complications from his drug use, so he had developed a cellulitis and has had abscesses requiring incision and drainage. And he has been involved previously in a treatment program in Toronto called the Fred Victor Day Program. Jake was found by his girlfriend with a decreased level of consciousness. His lips appeared blue and he was covered in his own vomit, and he seemed like he wasn't breathing, although he was in fact breathing at 4 breaths per minute. She tried to check his pulse, and it was very difficult to palpate, and she noticed that his pupils were pinpoint. So his girlfriend called 911. Jake was rushed into the emergency department, and this is a picture of the front door at St. Michael's Hospital Emergency Department in Toronto. When he arrived in the emergency department, his respirations were supported by bag valve mask. An IV was started, and he was given 0.4 milligrams IV of naloxone times 2. He then awoke, he became quite agitated, his rest rate returned to normal, his saturations picked up, and 2 hours later, Jake was awake and ambulatory. He was not interested in treatment, so he was offered referral to addiction medicine services. However, he was open to discussing how he could use more safely and how he could prevent dying from an opioid overdose in the future. So there are many risk factors for opioid overdose. There are multiple patient factors, opioid factors, and then there's polysubstance use. So some patient factors include, first, a loss of tolerance. So what I mean by this is somebody who used opiates and then perhaps went into jail where they couldn't access any opioids, was there for a prolonged period of time and then was released back into society and uses the same amount of opioids they used before. They are at very high risk of overdose because they lost their tolerance. Patients who have comorbidities, specifically comorbidities involving respiratory depression, would be a big risk factor for overdose. A previous overdose, so somebody who has overdosed previously is at risk for overdosing again, so this is a really good opportunity to intervene with Jake so we can prevent another opioid overdose. Using alone, because there's nobody to call 911, so that's why we always recommend that people do use together. There are opioid factors, so the potency of the opioids. If somebody is taking a prescribed medication, then they know the dose that they're taking, usually, if it's not a bootleg tablet. However, heroin comes in powder form, and so we don't know how strong that heroin is and if it's contaminated by anything like fentanyl. The route of administration can be a big risk factor. So is the substance snorted, injected, or smoked? And then polysubstance use. So people are at risk for overdose if they use other substances that could decrease their respiratory rate, specifically alcohol and benzodiazepines. What we're really talking about here is harm reduction. So harm reduction refers to the policies, programs, and practices that aim to reduce the negative health, social, and economic consequences that may ensue from the use of drugs and alcohol without necessarily reducing the drug use. So Jake is not ready to stop using, but perhaps we can give him some strategies to prevent harm from his use. Really, the roots are from public health, and it's really underpinned by the knowledge that many drug-related problems are not the results of the drug themselves, rather they're the consequence of the unregulated manufacture and the trade of drugs. An example of this would be distributing clean needles. So for somebody who injects substances, if they're sharing needles with their friends, they could be at risk for bloodborne diseases. So needle and syringe exchange programs would be an example of harm reduction. Another example of harm reduction is a take-home naloxone kit. So in Toronto, we have a program called the Preventing Overdose in Toronto program, or the POINT program. They distribute a naloxone kit free of charge through the Works at Toronto Public Health, which is located at 277 Victoria Street, and they also have an outreach van that distributes these kits. Anybody can go into the Works and pick up a kit for free, and then they receive a training session that lasts about 20 minutes. What is in the kit, as you can see, are 2 vials of naloxone, 0.4 milligrams in each vial, 2 syringes, a couple alcohol swabs, and then an information pamphlet on how to respond to an opioid overdose. This program did not start in Toronto. It really is a program that's been developed in the States and has expanded all over the world, and is currently endorsed by leading organizations, including the World Health Organization. This slide shows a few other examples of naloxone kits that are available throughout the world. So the top right-hand side are preloaded intranasal devices, so patients can receive naloxone intranasally. On the bottom right is a naloxone kit out of the States that is preloaded syringes. And then on the left is an auto-injector called Evzio that acts very similar to an EpiPen. So it actually talks to the patients and tells them what to do. Got it. So who is eligible for these kits? So luckily, the American Heart Association